Good evening. You're very welcome to the fourth webinar in our 2021 series tonight on ACL injuries. My name is Dr. Noel Pollack, and I'm a consultant in sport and exercise medicine at the Institute of Sport, Exercise and Health here on Tottenham Court Road in London. The ISCH provides excellence in exercise prescription, injury prevention and injury management for both elite and amateur sports people. For more information about clinical services and to view recordings from previous webinars, please visit our website www.iseh.co.uk. So I'm delighted this evening to be joined by our team of experts who have combined years of experience in elite sport and specifically with ACL injury. We have three 15-minute presentations for you, followed by a Q&A in the last part of the session. If you do have questions for any of our panelists, please just enter them in the chat section on the right-hand side of the screen. Feel free to share the content tonight on Twitter and tag at the ISEH. So our first speaker is Professor Faris Haddad. Faris is the Clinical Director of the ISEH and a Consultant Orthopaedic Surgeon at UCLH and the Princess Grace Hospital. His clinical and research interests centre around hip and knee reconstruction, including complex joint replacements and lower limb arthroscopy, ligament injuries and reconstructive surgery. Faris is going to talk to us tonight on some of the challenges of ACL injury. Faris, over to you.
Noel, thank you. Thanks for hosting this and thanks for the introduction, and good evening, everybody. My role today really is just to set the scene. I think the important presentations will come from Paul and from Leanne on the important aspects of getting athletes back to what they really want to do. But I thought it was an opportunity at least to share with you some of the things that go through our thinking in terms of how to look after ACL injuries and what the current challenges and paradigms are. So the plan is to talk a little bit about the problem in general. I'm going to cover what I call optimal management, but that's really very individualized to the individual patient, their problem, their presentation, and their aspirations. Talk about associated injuries, because I think that's really the big differentiator to what outcome we can deliver, and a little bit about how our practice has changed. And that'll all be enmeshed, and none of that I think is radically new. So hopefully it'll just be a recap for some of you of some basic concepts. But when I think about ACL injuries in sports, what worries me is how common they still are. It's a problem we face every day. In reality, this season, it's been a massive problem in elite sport, maybe because of the crowded schedules, maybe because COVID disrupted things, maybe because pre-seasons were very short, but we've been faced with a massive increase in injury rates. And there have been lots of injury prevention initiatives, many of which are very laudable, but they haven't really delivered what we want, which is a dramatic reduction in knee injuries and ACL injuries in particular. The young, particularly adolescents and young adults, are the most vulnerable, not just to primary injury, but also to re-injury. It's a sobering fact that if a female from the age of 16 to 20 tears her ACL and has an ACL reconstruction, there's a 25 to 30% chance of a return for further surgery to either that knee or the other knee within the next 5 years. So it's a major issue for patients, it's a major issue for sport, both elite and sub-elite level, and for society. If we start at the very basic level, it's remarkable that we're still seeing ACL injuries go unrecognized. To most of you on this call, because you're interested, the pattern is clear. Somebody feels a noise, here's a pop, here's a crack, there's immediate rapid hemarthrosis type swelling. They often can't carry on, they have giving way. That's a pattern that we recognize straight away as an ACL injury until proven otherwise. But unfortunately, that's not the case in every A&E in the country. And many of these patients still present to us late. And I think one of the confusing issues is that most ACL injuries are non-contact. So they are change of direction, whether internal or external rotation, hyperextension injuries or otherwise. So the contact injuries are in a minority relative to the non-contact injuries. And in fact, they tend to be more complex. And that affects the treatment and the management, because we tend to lump them all together as ACL injuries. But I want you to leave this presentation thinking that each injury has a personality, and we have to work out that personality and determine how to treat it from that. Imaging is straightforward. We get x-rays routinely. The reality is MRI scan is now easily accessible and tells us what's going on, not just with the ACL, but with the bone bruises, with the associated injuries like Sagon fractures or meniscal tears. It really gives us the pattern of what's happened to that individual and how that knee is going to behave. Bear in mind that not all ACL injuries have a massive hemarthrosis. 10% have a relatively quiet knee. They don't all have big bone bruises. Some of them have fairly minor bone bruises or are recognized when the bone bruise has abated. The management is very variable. There is one pathway for the elite and the sporty, and there's probably another for what I call the accidental victims. We haven't really had a ski season of note this winter, but there are lots of non-sporty people who tear their ACL for a variety of reasons, and their journey is often different, partly because of their demands, partly because of their rehabilitation potential. There's a big debate about early or late intervention, and we can cover that. And the reality is you've got to look at the patient as well as the injury. That's building up that personality and think about the whole pathway. So what is that patient's aspiration? What do they want to be doing? Will they follow the rehab? Can they actually achieve what they want to achieve? And can we help them to get there? And if so, how? So I think decision making is probably the critical thing. We've got to a stage where the surgery is actually relatively straightforward. Lots of people have been taught how to do an ACL reconstruction and frankly can do it, but actually is the decision making as to when and how and what else needs to be done at the time that differentiates. Sometimes there's frankly a risk to delaying. If someone's got an associated posterolateral or medial ligament that needs repair, if someone's got a ramp lesion or a meniscal root tear, if someone's got an osteochondral injury, there are reasons sometimes why it's worth going in early. And then there are patient-specific reasons in terms of their alignment or other problems why our decisions will evolve based on the patient that we're looking at. I think psychology is key. It sounds daft that a surgeon's talking to you about psychology, but actually it's the mindset, it's how that patient is going to cope with the injury that's probably the prime determinant of what their rehabilitation potential and their outcome is going to be. And we did some work that we sadly didn't publish years ago on this, basically showing that your compliance and your desire to attend rehab had an influence on your ultimate function. If in doubt, the easiest thing to do is to monitor the patient, settle the knee down and rehab. Unless there's a compelling reason to do something, rushing in is not a great idea. Let's work out the personality of the injury and the patient and what they need to do. So in terms of management, we can go non-operative. There's a small subsection suitable for repair, and we can reconstruct, which is the majority of surgical procedures. I think the big fear for everyone is what happens to that knee afterwards. And I think the reality is very simple. If you tear your ACL, your risk of osteoarthritis is increased. No matter how good your S&C, how good your physio, how good your surgery, how good your brace, your risk goes up. If you happen to lose your medial meniscus, your risk goes up dramatically. And so we've all got to bear that in mind and just accept it. What we're dealing with is symptoms and aspirations in terms of physical activity and trying to preserve the knee, but the risk of OA has gone up, the die is cast as soon as that injury has happened. Frobel and others have shown us that in a non-high demand, non-elite population, we can manage a load of patients very well with good non-operative management, and only about half of those end up needing an ACL reconstruction. And so if there aren't any of those associated lesions that I shared with you, and if this is not an elite athlete, it's pretty reasonable to consider a good rehabilitation strategy. With one of my other hats on in the NHS, we've got to work out how to fund and provide a good rehabilitation strategy, but that is possible. The big fear amongst surgeons, and surgeons like to do things, as you all know, was that meniscal injuries would go up with this strategy, but actually they haven't gone up dramatically. So it's a clear message there that there is a role for non-operative management for the non-elite ACL injury, and then you evaluate unless there's a good reason to intervene early, and you can still get a good outcome from late intervention. The other thing I would put to you is that some ACLs genuinely heal. I've shown this slide before, the old mantra that they don't heal. There's no question that the picture on the left shows a proximal ACL tear, and there's no question that on the right that has fibrosed and reconstituted, and that patient had a stable knee and didn't need surgery. didn't have a repair, didn't have any surgical interventions. So some patients do scar sufficiently to function well, and we should give them that opportunity. Repair has come back to the fore in the last 7 or 8 years, lots of direct-to-patient marketing. The reality is it's something we all dream about. It is very useful for the avulsion injuries, particularly on the femoral side, but there's very little evidence that it's superior to standard reconstruction. I had to revise 3 repairs in the last 12 months, so it is something that seems to be failing reasonably regularly. My worry about it is it's pressurizing patients into quick surgery who may not particularly need surgery. And so I think we've just got to be careful. That role is not clear. There's a few patients that need it. It's not anywhere near as big as the proponents suggest. But I would imagine, I would dream and hope that in my lifetime, there'll be some kind of scaffold that we can put in the knee if needed that can either help the ACL heal or that can have growth factors and cells around it to create a sort of biologically active mechanism for reconstructing or repairing and reconstituting the ACL. For all the physios on the call, that would remove that horrible donor site morbidity you all have to deal with. The reality is right now, many patients still benefit from ACL reconstruction and it works pretty well. It's particularly mandated if somebody is very young, active, has a meniscal tear, or is involved in cutting or twisting sports. So I started off at the beginning talking about the personality of the injury, and that's what the patient wants to do, and that's what the knee is behaving like. And once you've got a repairable meniscal tear, I think there's a really good reason to intervene. And if you have to repair a meniscus, that meniscus isn't going to heal unless you have a stable knee. So you need to do the ACL at the same time. So if the patient's got appropriate rehab potential and they're appropriately counseled, then we have a surgical strategy that I'm not going to go into great detail that works pretty well and generally allows for a good functional recovery. People get very fussed about graft types and debate them. In reality, BTB, hamstrings, quads, all work very well. We have specific reasons and patients have specific reasons for requesting one or the other, and some clubs are obsessed with one graft or the other, but the reality is they all worked. Allograft, I'm not a huge fan of, except in the low demand older patient. We sometimes use them in revisions. Artificial ligaments don't really work well for the ACL. And in a revision situation, you've also got access to the contralateral knee, so there's plenty of graft materials. One of the new things to consider, and you'll all be becoming more familiar with little scars on the outer side of the knee, is the extra-articular tenodesis. I would say that's mandated in the strongly pivot positive patient, in the hypermobile patient with hyperextension of more than 10 degrees, generally in the elite who want to get back to sport very quickly, and in other high risk or uncompliant cases. And we tend to do it in revisions too, because it becomes a high value knee. You all want to know about outcomes. The reality is the outcomes in the elite are absolutely stellar. These are conditioned, committed, devoted athletes with great physio support, and almost all of them get back to where they want to get back to. Different time frames, but they will get back to, from Schalke Brits playing in a World Cup 5 months after an ACL MCL to people taking 18 months. But the reality, elite will get back. Sub-elite is a different story. In the sub-elite, patients avoid a revision or further surgery a lot of the time, and we can talk about 90% success rates. Tough to know whether that's really replicated generally, because most people don't enter their data into our national registry. But if you look into return to sport, to the sport those patients did before their injury, less than 3/4 will actually get back to that sport. I said to you at the beginning that I think the key these days is the associated injuries and associated surgeries. And it's what you do with the menisci, particularly the root and ramp lesions, that matters. It's what you do with the associated collateral injuries, particularly medial, posterolateral, that will make a difference to the outcome, because those are the more sophisticated aspects of that care that we need to bear in mind. I'm not going to dwell on rehab. You're about to hear a lot more about it, but I think that's the critical feature that gets elite athletes back. It's not just good surgery, it's good rehab, it's good S&C, it's good reintegration. So that has to be part of the package for everybody, and that's often truly not delivered. Failures do occur. I'm not going to talk in detail about them, but I think poor compliance, poor decision making, a poor choice of technique or poor technique per se, or poor rehab will all lead to that floppy ACL that's partially torn that you can see in that slide on the right. This is just meant to be a way of background. I just wanted to stress that the ACL in reality hasn't been resolved. It still presents massive challenges. And I think you've got to be careful because there's lots of experts out there that say everybody should have X, be it hamstring graft, be it non-operative management, be it that kind of brace, be it a repair. And the reality, I think a lot of those are armchair experts. Actually, there is a level of sophistication around understanding the injury personality and delivering bespoke management. There is not one answer that suits all ACL injuries. And at the end of the day, if your athlete, your friend, your family member has an ACL tear, what you're looking for is a guide to the personality of that injury and how it's managed. It's the decision making that makes a difference rather than the ability to deliver the intervention, be that physio, S&C, or for that matter, surgery. I think many patients will do fine non-operatively. A smattering will benefit from repair, and hopefully we'll crack that over the next 20 years. Reconstruction works for those who need it, and I hope for the next half hour and in the discussion we're going to hear where we really are at ISCH in terms of rehab and reintegration into sport after ACL injuries. So thank you for listening to me. I'm sure you're going to hear much more important stuff in the next half hour, and I'll look forward to joining you for the discussion whenever Noel says I'm allowed to answer questions.
Thank you very much, Iris, for the first talk this evening. And yes, for the discussion, please do put your questions in that chat box on the right of the screen, and we'll come to them at the end of our 45 minutes. Our next speaker is Paul Reid. Paul is the General Manager of the ISCH and an Associate Professor at UCL and the University of Gloucestershire. His previous roles include Clinical Lead Researcher at Aspetar and Senior Lecturer in Strength and Conditioning at St Mary's University in London. Paul has consulted with many elite athletes and authored over 100 research publications. His recent research focusing on assessment strategies for lower limb, with a specific interest in assessment following ACL reconstruction, and it's that assessment that we're going to hear about today. Thank you, Paul.
Thanks, Noel. Just hopefully opening up the file. I think I'm back. Can everyone see my screen, hopefully? Okay, apologies for that. Thank you, Noel. Good evening, everybody. And I'm going to talk to you today about optimizing athlete assessment following ACL reconstruction. And hopefully I'm going to put the case to you that we can do better than some of the existing practices of hot tests and looking at peak torque. So just a bit of an overview and a return to sport 101. So what it involves is passing a battery of tests in the final stages of rehabilitation with specific pass criteria. And in this case, what's most often been used is a 90% limb symmetry index threshold to clear the athlete for a return to sport. And what we can see on your right-hand side is a common battery of hop tests that are often used, ranging from a single leg hop for distance, for a triple hop, timed hop for distance across 6 meters, and a crossover hop. And also commonly used is an isokinetic assessment of quadriceps and hamstring strength. So what does the evidence show? Well, it's equivocal at best. There's two most prominent reviews that have looked at this, and what they found is that the evidence is as I mentioned before, is equivocal. So a review by Webster and Hewitt showed that passing significantly reduced the risk of ACL graft rupture by 60%, but at the same time, they also showed that passing the same battery increased your risk of contralateral injury by 235%. So obviously we can see a bit of a mismatch there in terms of the findings. Also as well, a review by Lossial et al. Showed that passing did not show any significant association with second ACL injury. So just moving forward, this kind of led us to think a little bit more critically about these tests and specifically some of the methods used. So we examined the HOP test, and what we suspected was there wasn't too much in terms of methodological rigor in terms of how these tests were actually administered. So what we did is we actually reviewed the methods of all 17 papers within the Webster and Hewitt review using some of the criteria that you can see on the top of your screen. So for example, the testing order, was it replicated? Did they include and state their warm-up activities? Did they have a familiarization session? Did they look at the best or the mean score, for example? And the color coding that you can see on your screen essentially shows that it was coded green if they reported it within the methods and it was aligned to current evidence. It was coded as yellow if it was reported but not aligned to current best practice evidence. And where you can see the red indicates that they didn't report it. And obviously what you can see on your screen is a lot of red. Now, often we give authors the benefit of the doubt and think that they refer out their methods. So we also did that as well. And what you can now see on your screen is the same process performed on studies cited within the methods. And again, you can see a lot of red. And probably most importantly from this, what we saw was that sometimes in cases where authors did refer out their methods, they might cite 2 or 3 papers, but unfortunately those papers didn't always use the same method. So therefore it's very difficult for the interested reader or researcher to be able to determine what was actually done. So this led us to think a little bit more deeply about some of the tests and what they actually examine and what they've shown over time. And while there's a number of things that we identified, some of the main standout messages were the blanket use of limb symmetry index threshold across all tests, and we'll talk about that in a second. A lot of the tests measure similar constructs and perhaps have a lack of focus on the knee, which is obviously an important structure following a reconstruction. And also, we need to examine the movement strategy a little bit more closely and not just the outcome. So we hypothesized that horizontal tests, so horizontal hopping, like the test I showed you earlier, don't target the knee as much as perhaps we would like them to, in this case, in a return to play scenario. And recent work from colleagues over at Aspetar actually demonstrated this. So what they looked at was the joint contributions during a vertical hop and also during a horizontal hop, similar to what would be used in an ACL return to sport test battery. And what they found was in the vertical hop was a more equal distribution across joints and obviously placing a large emphasis on the knee. Conversely, in the horizontal hop, as you can see on the figure on your screen, actually only around 12% of the contribution in propulsion comes from the knee, and there's much more of a reliance on the hip and ankle to generate the required force to obviously hop forward horizontally. And this has got implications if your only outcome measure that you're going to use is the distance hop, which is obviously commonly reported within the ACL literature. Similarly, if we go back to the blanket use of limb symmetry index thresholds I spoke about before, trying to get above that, that barrier of 90% limb symmetry or 10% asymmetry. Now, what we've shown from a lot of the work that we've done previously is that asymmetry is task and variable dependent. And you can see this on your screen by looking at some of the tests that we measured in a large cohort of professional soccer players. So for example, if we look at hamstring eccentric strength at 60 degrees per second measured on an isokinetic dynamometer versus a Nord board assessment, which both are designed to characterize eccentric hamstring strength. And then if we look at the classification of very large asymmetry, we would see that we would get a different picture depending on which test we use, even though they're designed to measure the same physical construct, which could be problematic in terms of our decision making. Similarly, even within the same task, so if you look at the box down the bottom of your screen, within a single leg counter movement jump, which is that vertical hop we spoke about earlier, if we looked at the height jump versus the force produced, you would have a very, very different threshold, which would determine very large asymmetry. So I think the key message from this is that we want to be careful in the utilization of blank symmetry thresholds across all measures and across all tests if we really want to guide our decision making more clearly. We spoke earlier about the importance of analysing the movement strategy and not just the outcome, and some of the work of Enda King and colleagues over at Sports Surgery Clinic. And this is some really seminal work. They analysed a range of tasks. They looked at the performance outcomes, so jump, height, change of direction, time, distance hopped, etc., but also the biomechanics in terms of the movement strategy. And what they found was that the distance hop had normalized around 9 months after ACL reconstruction. So there was no difference identified between limbs or even between groups, but actually there was significant biomechanical differences in the way that they executed the task. And similarly, we looked at this in the triple hop for distance. And what we did is we looked at the distance hop across the 3 maximal hops as is standard for an ACL return to sport battery, but we put down an OptiJump track during the task. And from this, we could measure the contact time, so how long they were in contact with the ground, and the flight time, so how long they spent in the air. And what we found was that just looking at the distance hopped didn't identify some of the residual deficits in reactive strength ratio, which is the ratio of the flight time compared to the contact time. So how effectively you can switch from an eccentric to a concentric contraction. And also as well, we didn't just look at the total distance, we looked at each individual hop. And what we found was that there was differences between hop 1 and hop 2. So again, I think this just highlights that looking at the total distance hop would only give us some quite limited information in terms of how the athlete performed that task. So far I've spoken about hop testing, but also, as I mentioned earlier, isokinetic assessment in terms of quadriceps and hamstring strength is also commonly used in return to sport test batteries. And the most commonly reported variables are peak torque, limb symmetry index, and also the hamstring to quadriceps ratio. And if you just look at peak torque, you will actually only be looking at 2 individual points, which you can see on the torque time curve here. And in this case, the athlete would have actually passed the assessment with a 92% limb symmetry index just based off the peak torque. But by looking at the whole curve, you can obviously see that there are some deficits, but these would not necessarily be identified if we just looked at the outcome of a dynamometry assessment as a peak torque alone variable. So in some of our more recent work that we have under review now, we've started to characterize and explore the whole torque angle curve. And what we did in this case is we assessed athletes at 3 time points during their rehabilitation following ACL reconstruction. So at 4 months, 6 months, and 8 months, as you can see on your screen. And if you look at the first torque angle curve at 4 months, you can see that there's between limb deficits all the way along the curve, which you'd probably expect. And then when we moved across to their 6-month assessment, the between limb deficits were still present, but they'd reduced slightly. So now the deficits are only present between 30 degrees and 80 degrees. And then when we looked at the assessment around 8 months, the deficits had reduced again in terms of over which angles they were present between 50 and 80 degrees, so during deeper knee flexion angles. So using this approach, it not only gives us the ability to quantify a deficit, as in we would have if it was peak torque, but also to actually characterize it. And this has got important connotations for rehabilitation and targeted exercise prescription. So while we're still going to perform movements through the full range of motion, we might also want to consider looking at some positional isometrics and also, again, some possible partial range of motion so that we can ensure and restore full knee function across the entire range of motion. I also mentioned that hamstring to quadricep ratio is a common variable used. And what all this does, it just looks at the ratio between the maximal torque produced of the hamstrings versus the quadriceps. And a ratio of around 0.6 has been recommended commonly within the literature. Now, the issue with this following ACL reconstruction is we know that quadricep strength deficits are a known outcome following ACL reconstruction, and these can last for a year or more, or even 2 years after ACL reconstruction. So what you end up with is actually an altered ratio. So it actually looks better in terms of the hamstrings look better relative to the quadriceps, which doesn't necessarily paint a full picture. And also as well, what we should probably consider is the angle at which the peak torque occurs. So the peak torque angle for the hamstrings is different to the quadriceps, but just looking at the peak torque alone and looking at the ratio doesn't account for this. And when you actually look at those ratios, I mentioned before, 0.6 has been recommended within the literature, but the ratio can actually range from 1.7 in positions of outer range, so shallower knee flexion angles, all the way down to 0.4 into some of those deeper knee flexion angles. So it's probably not the ideal scenario just to take a blanket ratio using the peak torque, and we probably want to examine our torque production across our quadriceps and hamstrings and look at ratios across the entire torque angle curve. So far, I don't want to discredit previous literature, but by acknowledging and learning from some of our work from the past, it's possible to accept some of the uncertainties and possibly limit the claims based on some overinterpreted research. So what I'm going to spend the next part of the presentation talking about is some things that perhaps we can consider moving forward to try and optimize our athlete assessment in terms of their return to sport journey. So what you can see on your screen now, unfortunately my slides are not working effectively. You would have seen a nice video of probably one of the world's best athletes performing a vertical jump. Obviously that's not true, it's just me. But what you will see is that I'm standing on a dual force plate system, which is provided by companies such as ForceDex. And what you can do in this situation is you can characterize and measure the ground reaction force on both the right and the left limb at the same time. So therefore you can obviously measure ground reaction force from the involved and the uninvolved limb. And what we know from previous literature is that ground reaction force is related to kinetic knee asymmetry. So therefore it would probably given us a stand back broad interpretation of how their knee is functioning during a dynamic task. And also as well through the process of integration, we can actually break the movement down into different phases by calculating the center of mass velocity. And you can see by the graph on your right, the athlete will start standing still and then they go through a period of unweighting. And then from here, they will obviously then start to go through a period of rapid braking. And that will occur when the center of mass velocity, that position of the eccentric phase will end at the point when the vertical velocity of the center of mass is 0. So they've effectively reached the bottom position. And then from here, they will obviously go through their propulsive phase where they're trying to jump up in the air as high as possible. So we can use this type of assessment, which is very, very quick to perform. It's a performance test and requires low familiarization to give us a lot of information about how an athlete is actually performing the movement. Now, unfortunately, you won't be able to see it because my slide's not working, as I mentioned before, but underneath here, there is a force time curve, which would characterize a normal ACL reconstructed patient. And what you see is that the athlete will actually produce much greater forces on the uninvolved limb, pretty much all the way throughout the eccentric braking phases and through propulsion. And then obviously when they land after the time in air period, you will also see that they land with a greater force production on the uninvolved side, probably through a means of as a protective mechanism or of a learned pattern of disuse. And what we've seen from our analysis, which we published in the American Journal of Sports Medicine, was that this process can be present for 9 months or more following reconstruction. And even in some of our previous work, when we've looked at athletes that have returned to sport up to 12 months after that point, these deficits can still be present, even though they've actually returned to performance in terms of their jump height. So they actually jumped similar to their colleagues who hadn't had this severe previous injury. They just used an altered strategy. Now, so far, I've just given you an example of a bilateral test, and there's obviously a lot of discussion around using unilateral tests. And we'd hypothesized that it's not an either or. Actually, you probably just need to use both. And some of the reasons for that you can see on your screen. When we use a unilateral task, we actually have to support more of a greater percentage of our body weight above our hips. And what that means is that we need to produce more force relative to the limb as a consequence. And as a further consequence of that, the actual velocity of the movement will be slower. So what we would suggest, and other authors, so for example, Daniel Cohen's group, have suggested that single leg tasks and tests are actually probably a truer measure of capacity, whereas a bilateral tests, which are faster and have higher velocities, will measure interlimb asymmetry, so how you distribute force between limbs and how an athlete will self-organize under high velocity conditions. So they're both giving you an awful lot of information to use to guide your rehab. So what is the patient pathway then? So at the Institute, we have a multimodal approach. We look at a clinical assessment, we look at psychometric factors, we look at isokinetic testing of strength, but also isometric, looking at rate of force development, and then movement profiling using some of the biomechanical analysis that I spoke about before. And we do this from around 3 months and then all the way throughout their rehabilitation, so that we don't just measure at that return to sport period. We can actually describe and analyze and try and guide the patient journey. We can also use this information to inform our decision making. So again, using some of the data from our previously published work and using quartile analysis, we can actually start to characterize physical qualities to determine if an athlete is on task. So using the example that you've got on your screen, if we take an athlete that is over 9 months following reconstruction, if their eccentric deceleration impulse asymmetry, so the force production with respect to time during the rapid eccentric braking phase, is less than 3.5%, then you can see it's green, so therefore they've been considered on target. But actually, if they had an asymmetry greater than 12.4%, that might be delayed. So therefore, that opens up conversations with the rest of the rehabilitation and surgical team why that is. So perhaps there was comorbidities, they missed lots of rehabilitation, or they were just underloaded in their eccentric capacity. So just a case study to finish then of a professional soccer player that we analysed multiple times during the rehabilitation, and you can see an output from ForceDex on your screen, and their actual jump height improved linearly at each time point assessed during the rehabilitation, which would indicate good progress. But then if we also look at the concentric impulse asymmetry, so their force production during the propulsive phase relative to time, we can see that their asymmetry, as you can see the figure in your top left of the screen, reduced at each time point, and their isokinetic assessment again improved at each time point and actually fell within that 10% or 90% limb symmetry index at their final stage, which is obviously fantastic and all looks good. But then when we looked at their eccentric braking capacities, what you can see by the top left figure on your screen is that actually deficits were present throughout their rehabilitation and maintained on the athlete's return to sport. And what's interesting about this case is that the athlete injured his ACL in a change of direction movement, which obviously requires rapid eccentric braking capacity, but then obviously they went on to subsequently re-injure their ACL following return to sport. So we probably need to target these eccentric capacities to ensure that they're perhaps more safe to do so. And obviously that was an N=1 test case, but recent work again from the Sports Surgery Clinic have shown that these biomechanical deficits are associated with those who go on to get a second injury, whether it's to the same limb or to the contralateral limb. And particularly they identified deficits in plyometric ability. And just as a final one to finish, you can actually measure plyometric capacity using a drop jump and looking at the ground reaction force profile. And here you can see a characterization of a poor jumper, which is the red line, and a good jumper, which is the green line on your screen. And the main differences you can see is a very sharp impact spike and poor eccentric braking capacity in the poor jumper, and a much smoother curve in a good jumper, which would mirror the center of mass displacement on the other side and give you a very, very nice smooth spring-like curve indicative of good plyometric capacity and stretch shortening cycle function. So in summary, traditional approaches used following return to sport have some inherent limitations, and we now know that we need more comprehensive analysis to more clearly examine and characterize function. And while we're aware of what the deficits might be following ACL reconstruction, I believe that some of our future work should start to look at targeted interventions and also, again, really start to broaden out this research looking at associations with return to sport outcomes. Thank you for listening.
Thank you very much, Paul. Any questions for Paul, please add them in the chat section. A couple of people have asked on the chat as to whether we'll be providing certificates afterwards, and yes, I understand they will be emailed out. And others have asked for copies of the videos, and they will be available, as with all the webinars that have previously have been run from ISEH on the ISEH website. Our next speaker is Leanne Simoncelli. Leanne is a clinical specialist physiotherapist at the ISEH and completed an MSc in sports medicine at UCL. Leanne's worked with a range of sports teams and events, including international rugby, hockey and netball, and is going to speak to us tonight on integrating some of that assessment that Paul's spoken with into ACL rehabilitation. Thank you, Leanne.
Thanks, Noel. Appreciate that. Thanks to Professor Haddad and Paul. That was great. Brilliant talks. Let me kind of complete the athlete program, the ACL kind of return to play strategy. So how do we augment this optimal rehab training using the testing and training approach, like using some of the examples from Paul? So what I would like to discuss is the current return to sport frameworks. What are the decision-making guidelines, particularly to ACL? How can we minimize these huge number of secondary injuries? How we can optimize rehabilitation guidelines, focusing on muscle strength, neuromotor control, perturbation, reactive agility, contact impact, and what are the testing options that are available, and how can we optimize their return to performance progression? So what are the current return to sport frameworks? So ideally, it's the biopsychosocial framework, so criteria-based, multifactorial, sensory motor, including sensory motor spectrum, multi-segmental, interacting with the individual, the task, and their environment. There's a continuum on the return to sport pathway. Must be shared decision, the surgeon, the patient, the athlete, the coach, the physio, S&C, and there's a big picture. There's a consensus statement from 2016 with Claire Arden and team, really good description of how athletes return to participation and then to performance. So it's a real continuum. They use the START framework. Professor Haddad highlights that each ACL is very individual, and this highlights that each pathway is very different from an athlete's point of view. So what their take-home message was that the time from surgery and injury is still a very important factor, that we need to include the test battery. We can't just look at hop tests and quad strength. Then we need to include a reactive decision-making element to the rehabilitation and testing. There needs to be a gradual increase in workloads. They don't just go from the physio room to the field, and they need to be psychologically ready. What are some of the specific ACL decision-making guidelines? So Paul's gone through that in quite a lot of detail, but essentially we want to start from an ideal point of a calm, cool, quiet knee, and we want to make sure that they go through a series of test batteries. What that optimally is, we don't know quite yet. So in terms of the evidence base for rehabilitation, we go through a multi-stage process. So if they're going to have ACL reconstruction, there's a pre-operative phase, there's an acute phase after surgery or rupture, intermediate phase, late phase, and then after that, the injury prevention phase. And each has their own main goals. From the Panther ACL consensus group, they also highlighted that the criteria-based progression from participation to sport performance is a continuum. It's not just one time-based incident, and we need to include both functional assessments, psychological assessments, and we need to still consider the biological healing processes. So it's not just the time, but we still need to consider the time base. So those are the guidelines. What actually are we doing? Research shows we're still using time as a factor, strength, hop testing, clinical exams, patient reports, and performance-based criteria. Paul's gone into great detail about the hop testing, weaknesses or potentials for actually using it a bit more in depth, as well as the strength testing. This is a nice global framework for looking at the ACL person as a whole, looking at their flight time, their phase, their endurance, their neuromotor control, top-down weight bearing, the speed of an exercise, their trunk rotation control, multiplanar rotational axis, especially in those non-contact injuries, and obviously the eccentric focus on the landing. How can we minimize these second injuries? Either is it a re-rupture we can prevent, or injury to the other side? And what are these risk factors, and what is the mechanism of injury? So we know that young athletes, as Professor Haddad said, young athletes are the higher risk of re-injury. So even after they've passed the battery of tests of quad strength, functional hop tests, and symmetry, and reported outcomes, they're still failing. Some of the 9 months is the key time that reduces the risk after surgery. So there can be some, like Prof said, in terms of elite athletes that can return for that final in 5 months, but generally your risk reduces by 51% if you wait for 9 months. And quad symmetry is a very key factor to look at as well. But even passing these 6 tests still doesn't identify the risk that patients have. Prof highlighted that 44% are non-contact, but there is still a huge percent in football. At least 44% are indirect contact. So there's some perturbation, some interference, either just before or just after an event, and then direct contact. This percentage is higher in contact sports like rugby and in martial arts, and in netball, which should be a non-contact sport, but definitely isn't. Also interesting, we used to think fatigue was a major issue, but actually it happens in the first 26% happens in the first 15 minutes. So do they have the neuromotor control readiness when they're actually on the field for those first 15 minutes? In terms of optimizing a rehabilitation, what do we mean by muscle strength? So muscle strength is not just a 1 rep max. We are looking at the whole spectrum of muscle strength. So we're looking at muscle capacity, muscle endurance, the type of muscle contraction, so isometric, concentric, eccentric, muscle power, force of rate development. We need to test these. So in terms of ACL specifically, we don't want to just focus on the quads and the hamstrings. We want to make sure we're maximizing the capacity of the glutes, the hip rotators, the trunk, the abductors, adductors, and soleus. When we select ACL rehabilitation exercises, it needs to be both hip and knee based. You can see by the testing that Paul has shown us that there's a lot of ankle and hip involvement. We need to do both open and closed chain. The debate about closed chain, open chain, after 6 weeks, after they got a cool, calm knee, we should be pushing open chain. And we have to look at both inner, outer, and middle ranges. We need to incorporate short and long levers, slow and fast contractions, body weight, and loaded. Obviously, both double and single leg, as Paul highlighted, influencing different positions of the body, different weight distributions, and involving plyometrics. These are some examples. So obviously squats, lunges, step ups, banded exercises, adductor loaded, trunk loaded. How do we know that we test that the strength that we are testing is the correct strength? So we're lucky we've got a Bidex, the gold standard, but you can still use handheld devices. Manual muscle testing is just not good enough. Also, we don't want to just compare to the uninvolved limb. We try use an age and gender matched control or normative database that we have access to. Just as Paul highlighted, we don't just want to look at their peak torque or their peak hamstring quads ratio. We want to look at a bit deeper into the detail. So we want to look at how they produce, what does the torque look like over time? How do we optimize neuromotor control in rehabilitation? So we want to look at their movement quality. We want to look at their landing strategies. We want to look at their change of direction, including cutting, pivoting, acceleration, deceleration, dynamic balance, and time to stabilization. This is one of the risky positions. Do we want to train them out of this position, or do we want to make them more robust and resilient in that position? Just as Paul has highlighted, we need better standards of reporting. Hop tests can be useful, but just looking at the distance hopped, probably not enough detail. We know that athletes generally land in a stiffer knee, so they have less knee flexion range, they land in more extension, and they have more trunk flexion, and they load the opposite limb more. So we could analyze this with a counter movement jump. So we're looking at the braking phase, the propulsion phase, and the landing phase. And we're looking at limb-to-limb symmetry, we're looking at peak, and we're also doing the same thing. We want to compare them to a control group, an age and gender matched control group. How can we include perturbation in our training? This is really important, especially in that mechanism of indirect contact. So we need to not just consider them on the floor with perturbation, but we need to include it in before they take off, in their mid-flight, their peak height, their mid-descent, and on landing. We can analyze this with a drop jump, and we can look again with single leg to double leg, and we're going to not just match them to the involved leg or the uninvolved leg, we also want to match them to a gender and age matched control group. How can we include reactive agility and decision-making elements into our rehabilitation? So we can look at auditory cues, so using a sound that gives you a movement that you've got to react to. So you could use a whistle, meaning you go forward, a bell, meaning you go sideways, a buzzer that makes you go somewhere else, a beep makes you jump. You can call left or right, go forward or back. A color of the cone can mean something. Go forward when you go to the blue one, go left when you go to the right one, move back when you get to the yellow one, for example. You could call a shape of an object. When you go to a hurdle, you need to do a backwards jump. If you need to go to a cone, you know you need to go around it, and you can change that. Also, you can call a name or a number of a set play. So in NFL, they have particular patterns that they would run, so you could call that as well. We need to involve auditory cues, so either a person to mirror you, so you need to copy the movement, or you need to have a person to defend your movement, or you in defending them. And reaction to light, so if it's the blue one, you need to do something, the yellow one, you need to do something. So different variety there. So they're having to decide what they do. You can show them a video. The mid-video could suggest they need to do something, go back, go forward, go sideways, jump, twist, pivot. The color of the object, so when I call red, you need to do this. When I call blue, you need to do that. You could also use a reaction ball, or you can use a ball. So if I throw the ball, you need to do this. If you jump, if I kick the ball, you need to do this. If I throw the ball, you need to do this. And you can use different flags as well. So an aspect that is not really commonly used in physiotherapy is contact or impact training. So 12% of the ACL injuries in football were direct contact. In rugby, it's a lot higher, as well as martial arts. So you need to use a strategy that uses either open or closed chain contact. It's either athlete or physio driven. Athlete is running into you or into a tackle bag, or you running into them. You need to target different aspects around the knee. So ankle, shin, knee, thigh, hip, trunk, shoulder, arm. So you could use tackle shields, kick pads, punch pads, all the variety. So how do we optimize this return to performance pathway? Well, we know that we need to gradually increase the workload, and the athlete has to be psychologically ready. So the ideal situation is to do it on their sports setting, so their familiar ground, starting with pre-planned linear motions, so it's just straight forward and back, then pre-planned multi-directional and rotational movements, then adding the reaction tasks, then adding sport-specific drills with their equipment, so with their ball, their racket, their stick, or their bat. Then the team training sessions with no contact or impact, so very predictable, very planned. And then full training sessions with no restrictions. And then maybe feeding them into an exhibition match or friendly match first before they go on to a full competitive match. And then with that, they could maybe be a substitute, go in the second half or the final quarter. So in terms of female athletes, so obviously they're a special cohort mentioned by Professor, so they are, higher risk. So maybe females need to be highlighted that they're actually higher risk of re-injury or a primary ACL injury in their pre-ovulatory phase. So maybe coaches need to be aware, actually, maybe you don't have a heavy loaded session, or if it's a double header, they just maybe need to be aware, or do they need to control their hormones through various means. A nice way for female athletes to track their menstrual cycle could be using an app such as the Fertile Woman, really good and highlights different training phases that may match your cycle. So in summary, just a whistle-stop tour that normally takes about 9 to 12 months. So how we can optimally rehab our patients, focusing on muscle strength, neuromotor control, perturbation, reactive ability, and contact or impact training. What testing options are out there? We should be using them. So we should be testing, are we achieving what we aim to set out? Are we making our athletes as robust and resilient as they can? And what does the ideal return to performance progression look like? Thank you very much.
Thank you, Leanne. And if I could ask all the speakers to unmute and excellent. So questions please do add in the chat. I'd like to start us off perhaps by just picking up on Leanne's last point there on the female athletes. As a general question, how well represented are female athletes in the research? In outcomes from surgery and in prevention and rehabilitation. Maybe we'll start off with that. Who would like to take that? Faraz.
Sorry, no, I lost the connection. All I heard is female athletes. What do you want to know about them?
First question is, how well represented are female athletes in the research? Are we extrapolating, or is this a body of work that's well done in female athletes?
So I think it could always be done better, but in reality, the preventative work, a lot of the good preventative work has focused on female athletes, particularly the North American collegiate populations. So I think that's been a focus for the last decade or decade and a half. It's just not been as effective as we'd like it to be. So it's not a new message that females are at higher risk of injury per hour of sport, that they set unique challenges for us, both biomechanically, hormonally, and in other ways. It's just we haven't cracked it yet. That's the real problem. So I think they're pretty well represented. They're not well represented so far in the sort of soccer literature and soccer discussions in Europe, because that's been very male-centered, UEFA-centered. But otherwise, I think they are.
And in terms of surgical outcomes and surgical techniques, is there any different considerations there?
So I think it's all about, it comes back to the same premise that it's all about, how hypermobile is the patient, what are their demands, what's happened to the knee beyond the ACL, what are the soft tissues like. So yes, they are, and we know from the registries that the re-injury rates are high in young females. So I think you've got to consider them as high risk individuals, and we end up doing a higher proportion in non-elites of extra-articulars in females than in males.
Super, thanks, Faraz. And Leanne, if you just pick up on, you made the point on primary injury risk with the menstrual cycle. Considerations in the menstrual cycle for rehabilitation yet, or around return to play? Does that factor in your decision making at all?
I think in terms of both, actually. So I know within England netball, we know some of the girls that are really high risk, some of them already had ACL injuries. So we will tell the coaches, okay, so, just to let you know, X, Y, and Z, might be a bit vulnerable if they're doing a double header or, a high-low training. So we just say, maybe can we avoid that? She's a shooter, maybe she doesn't need so many change of direction across the court. So it's more about informing the coaches, just highlighting it to them.
Thanks, Leanne. Move on to a question from Paul. A question on dynamic functional ratio, eccentric hams to concentric quads, and if you have any exit criteria for that, Paul.
Yeah, no, it's a great question. Obviously, I spoke about some of the limitations of using a conventional ratio, so concentric quadriceps to concentric hamstrings, and obviously issues around interpretation of just taking one value irrespective of the angle. Obviously, going for a dynamic ratio or more functional ratio, looking at eccentric hamstring relative to quadricep will give us a better indication of how the joint functions in terms of like landing positions, braking capacities during change of direction during that plant step. I think I saw from the question as well that it was also a recommendation around specific angles, and I think they referenced an angle of around 30 degrees. So in terms of obviously towards full extension, which in my mind makes sense, because if we think back to the injury mechanism, that's roughly where the position of the injury is going to occur in some of those shallow and knee flexion angles. So having good eccentric hamstring strength, there's obviously a restraint to that tibial translation in that position, in my mind, would make sense. So yeah, fair point.
Thanks, Paul. Also a question for you from Corinne on time to stabilization.
Sure, yeah. So time to stabilization is an interesting one. So a lot of the literature around time to stabilization came from ankle patients, so like functional ankle instability patients, and originated a lot in sort of static balance type tasks, so single leg, eyes open, eyes closed, those types of things. From my experience, and we did a lot of this work with pediatric and youth patients, is it can be quite a noisy metric when you want to use it in jumping and landing tasks. We would see coefficient of variations of anywhere between 30 to 50%, which obviously indicates there's a fair amount of variability in the metric. And then if you linking back to Leanne's talk, if you want to measure something, you only want to measure something that you know has a potential trained and targeted outcome to it. And if you've got a measure that's 50% or more in terms of the coefficient of variation, you've got to be pretty confident that changes you see across time are obviously real or just noise within the metric. So I definitely think it's got an application, but it needs a huge amount of familiarization, and we probably need to consider what task we do it in. So, for example, doing a maximum horizontal hop and stick to then have a look at how quickly the athlete can stabilize. You'll get some information, but how much you can take from that, I'm not sure, to be honest.
Thanks, Paul. A question for Leanne from Claire Pedersen. Leanne, a question on open-kinetic gain quads and the rationale for waiting 6 weeks, rationale and evidence for waiting before introduction of open-kinetic gain quads.
You don't really want to wait. The time frame is not a factor. You want to make sure that they've got a cool, calm knee. So you might not do a loaded open chain. So yes, just the weight of the tibia is fine. But in terms of weight, actually loading it through either ankle weight or with a knee extension machine, you just want to make sure that they're stable enough. But there is some risk in terms of full extension. So you might want to work from, say, 90 degrees to 130 degrees. So yeah, it's not a time frame. It's just some people don't do open chain resisted exercises. So I'm just stressing that we should be doing it.
Yeah, thanks, Leanne. Also, pick up interesting questions through on you previously talked on sort of highlighting the risk, pre-ovulatory risk. Is there a risk of influencing psychological readiness for sport when I think may not be able to choose, when they need to compete at their best? Is that something you come across in elite sports you work with?
I've had the opposite. In fact, I've had female athletes say, why did I not know this information? Why did I not know that I was at higher risk at certain phases of the cycle? And a lot of female athletes can actually moderate their cycle, so they can control it. Some athletes don't want to be through their cycle for a major competition. So you can, and this is probably more your field as well, in terms of the SEM side of females regulating their cycle. But yeah, patients need to have we need to give them all the information that we do have, so they won't have they can do the risk assessment themselves. There is a link, so we know that the ligaments are more vulnerable, whether we make them psychologically ready, not ready for that. But yeah, I'd rather give my patients or my athletes all the information I can.
Yeah, I agree. I think that's a way of making psychologically robust athletes to provide them with good information at an appropriate time. Obviously, you're not telling them in the changing room before. So I was going to move on to the last question for Faraz related to surgical rationale, but I will leave that one because Matt Taberner's just put a great question in on workload and why do we use the term workload when it's how do we measure work, and do we need to be more specific with our terminology, quantifying training load, and then how that links into when you return to sport. I think a question on the measurement of overall training load prior to and around return to sport. Leanne, do you want to take that one?
Sure. I think in terms of workload, I think each sport has their own kind of criteria. So it could be the GPS on the athletes' backs. It could be number of steps taken, could be their training, the intensity of their training. Most athletes that I know have a very detailed kind of spreadsheet of what they're doing. They monitor themselves on Strava, on all the different types of apps. So they know their workload. They know how much they're training. They know how much they are competing. So in terms of elite athletes or sub-elite athletes, there's a lot of apps out there that can monitor workload, GPS or FitArt, loads of different easily accessible bits of kit.
Noel, can I jump in there? Is that right?
Absolutely, Paul. Thank you.
I mean, Matt, in fairness, has done a fair amount of good work in that area, so he's probably got better answers than we have, but I'll chime in anyway. So I think the difficulty with the term workload, and I think he's highlighted it in his question, is the term work or load is very non-specific, and we know that load can come from many different sources. And I think Matt's work did highlight, you know, it's also representative load, not just total load. So for example, 2 athletes can run 10,000 meters during a game of football, but that load doesn't necessarily indicate that it was the same by those 2 players. One athlete performed a huge amount of high intensity work with lots of rapid decelerations. The other one is you know, probably like me in my playing days, much more of a steady plod along type athlete. And obviously the demands of those are very, very different. So I think 2 things. I don't have an answer because I don't think there's any evidence in that part at the moment. I think we've got some good case studies, and Matt's put a few forward. I think we need to get better at characterizing the load, what tools we've got, and through wearable technology, and I don't just mean GPS, you know, because GPS is limited in its application to characterize some of this stuff. We need to make sure that we can find ways to measure the different types of load, but also we are exposing our athletes incrementally to the different types of load. So for example, doing a change of direction in closed conditions where there's no environmental stimuli is completely different than doing it in a perceptual stimulus response scenario where I've got to react to balls, players, and so on and so forth. So I think it's about graded exposure, and obviously Matt highlighted that really well in his work. Being able to measure some of this stuff, and I'm not sure I have a good answer on that, but that's something we want to work on moving forward. Yeah, again, a long way of saying I don't know, but those are probably some of my viewpoints.
Thanks, Paul. I think that's a good one to end the discussion on. I'd like to just give the opportunity to any of the speakers, if there's any other business, any other comments before we close.
No, only to say that there are other questions I see appearing, and if people want to contact us, ICH, they're very welcome to get in touch, and between us, I'm sure we can address any issues that they have or point them towards others who have expertise in that area. Because, for example, we do have people whose sole focus in life is female athletes and how to optimize female athlete performance, and we've also got other surgical and rehab experts who'll be able to pick in. So feel free to contact us at ICH.
Super, thanks, Faraz. A great message to finish with there. So just like to thank the panelists for their expertise this evening, for all the participants for the questions, and for joining us this evening. Certificates will be sent out on email. Videos will be available on the ICH website, and we look forward to seeing you at our next webinar. Thank you.